by one. Yeah, Prabhakar. Uh, Myself, Dr. Harshodhan Patil.
I am Dr. Deeptesh Das.
So let's start with role of amniotic membrane transplantation in acute ocular manifestation in Stevens-Johnson syndrome by Dr. Prabhakar Singh.
Hello
The time limit is set to 5 minutes.
everyone. The title of this presentation is Role of Amniotic Membrane Transplantation in Treating Acute Ocular Manifestations in Stevens-Johnson Syndrome. We all know that the Stevens-Johnson Syndrome sequelae can result in corneal vascularization, lid margin keratinization, and subsequent lid hyperkeratopathy and severe dry eye, and adding to the morbidity by causing corneal opacity. These conditions can be prevented by doing amniotic membrane transplantation in the early stage. Let me take you through a case of an 18-year-old female who suffered Stevens-Johnson syndrome. She was a known case of seizure disorder and on various anti-epileptic medications. She developed multiple flaccid bullae and purpuric macules with sheet-like epidermal detachment along with multiple mucosal site involvement. At presentation, there were scabs over the face, lids. There were deepithelialized lid margins, crusting at the lid margin with matting of eyelashes, mechanical eversion of the lower lid margin with temporal and chyloblepharon. There were diffuse bulbar conjunctival congestion with blanch palpable conjunctiva. There were true membranes over the conjunctiva. There were desquamated sheets of conjunctival epithelium attached to the lid margin and over the cornea. There were nasal and temporal and chyloblepharon. Here in this picture, the red line shows the grey line. The green line represents the posterior lid margin, and the structure behind the posterior lid margin is a deepithelialized epithelium attached to the lid margin. So, a final diagnosis of Stevens-Johnson syndrome with both high grade 3 ocular involvement was made and amniotic membrane transplantation was done. The true membranes were first peeled off, the symblifera were released, the furnaces were swept, then the amniotic membrane was draped over the ocular surface. It was stuck in with the help of a ring made out of infant feeding tube number 10. This ensured that the amniotic membrane is spread not only over the cornea and adjacent conjunctiva but also to the furnaces. The redundant amniotic membrane is reflected onto the lid margin. This was the post-operative regimen, and these are the pictures at 7 post-operative day. So the question arises, how can this prevent corneal vascularization? This is the clinical picture of the same patient 1 year post-operatively, wherein we can see that the cornea is clear. That means the limbal stem cell damage can be mitigated by doing amniotic membrane transplantation in the early stage. The exuberant inflammation can result in lid hyperkeratopathy, and this can also be prevented by doing amniotic membrane transplantation in the acute stage of Stevens-Johnson syndrome. These are the clinical pictures where we can see that there are no lid hyperkeratopathy. These are the serial photographs showing direct assessment of tear secretion in the same patient, wherein we can see that post-operatively there is no severe dry eye and there is active tear secretion from the right eye as well as from the left eye. So the take-home message here is one should have a lower threshold for doing amniotic membrane transplantation in this condition, and acute inflammation, if it is controlled well in time, can prevent the disease course. These are the clinical pictures wherein the upper two did not receive amniotic membrane graft in the early stage. However, the lower two received amniotic membrane graft in the early stage, and this is the outcome over years. Thank you. Thank you, sir.
Treated it in early case.
Right.
What would be your treatment modality if it presented a late case?
So it depends on what is the scenario at that point of time. So the first thing that we do in such patients is that we stain the ocular surface. If the ocular surface staining is 0, that means it is completely epithelialized. Nothing has to be done at that point of time. We just have to now wait and watch to develop for the development of those sequelae, chronic sequelae like lid margin keratinization. If it happens, then we will tackle it with oral mucous membrane grafting. But if the patient comes to us with a epithelial defect, be it conjunctival, be it corneal, we'll have to cover that with amniotic membrane. So it would be better if we tackle such scenarios, such clinical cases at the earliest, like within 7 to 10 days. Thank you, sir.
You used any glue?
No, in this case, we did not use any
Just the
glue.
retention ring.
So yeah, the ring was big enough that it was holding the amniotic membrane firmly, and it was stretching the amniotic membrane even to the supratemporal fornices where the lacrimal ductules open. So the chances of lacrimal ductule area scarring is also decreases, and hence the risk of dry eye.
Any purposefulness in not using sutures or anything?
We know that we have done plenty of cases by now, so we know that the ring stays very well. And by the time the amniotic membrane dries up at the lid margin, we don't need any suture to hold it even at that place. So it stays at place very nicely. Thank you so
Any
much.
questions from the audience? No. Thank you.
Thank you.
Surinder Kumar. 262.
Neck
60. Yeah, yes. 260.
The next presenter will be Dr. Surinder Kumar.
We are presenting.
So I'll be presenting my technique Z-Vac soft chop, smart and soft way to chop the nucleus in phacoemulsification soft cataract. So I'll just play audio video.
We are presenting our technique ZAC soft chop, a smart way to chop the nucleus and phacoemulsification of soft cataract. Phacoemulsification of soft cataract does not be a cakewalk always. The main fear is PCR. Conventional phaco techniques of direct chop and divide and conquer are not safe in soft cataracts NS grade 1 and 2, which require nuclear disassembly. It is risky to create and hold on phaco tip as there can be unwarranted occlusion break and dangerous surge due to sudden aspiration of soft lens matter in front of the phaco tip. Even subtle disproportionate phaco parameters can result phaco needle instantly bore through the soft lens nucleus resulting PCR. The ZAC soft chop technique employs zero vacuum and obviates the need to create a hold on the phaco tip. Instead, nucleus is simply supported and stabilized with phaco tip while chopping, thus minimizing the PCR risk. Here goes the technique. Surgery is performed using anterior chamber maintainer. A CM port and two side ports are made using 20 GV lance knife. Main port of 2.8 mm is made with slit blade. A CM is inserted, and capsular hixus is crafted with 27G bent needle under fluid with bottle height of around 60 centimeters. Routine hydroprocures, hydrodissection, and hydrodelineation are performed. Nuclear rotation is performed to loosen cortical lens matter from the capsule. Supranuclear soft cortical lens matter is aspirated using vacuum of 100 and US energy of 20, both in linear mode. Surgeon is using Venturi phaco system. Now, a small pit is crafted in sub-incisional area just inside the rhexis margin. In 3 to 4 strokes using very minimal 3 to 10 US energy. Now, comes the chopping of nucleus. Foot pedal is shifted to 0 position with continuous irrigation on. Phaco tip is supported in the depth of the pit. Blunt chopper is slid under the anterior capsule and lens equator is hooked. Now, chopper is moved centrally toward the phaco tip. Tip is held firmly in the pit to support and stabilize the nucleus while chopper is moved centrally, thus creating nice chop dividing the nucleus in two heminuclei. Now in the same way the second and third chop is created by supporting the phaco tip on inner planar side of the heminuclei and hooking the equator with chopper under the anterior capsule and pulling toward the phaco tip. 4 nuclear pieces are created. Now, the pieces are nudged and hooked and brought toward the center one by one and are emulsified using vacuum 250 US energy 20 in linear mode. Epinucleus is removed using vacuum 450 mm of mercury and US energy 20 linear control. Cortical cleaning done with 23G cannula fitted on 10 cc syringe. Lens inserted under fluid only. This is a case of 50-year-old female patient high hyperopic, +9 diopter for clear lens extraction. Capsular hixis is performed under OVD. Please note that during the chopping action, foot pedal position is always in position 0 with continuous irrigation on. So, there is no risk of phaco tip penetration through the lens mass. Occlusion of the tip in nuclear hold is not required in this technique. Instead of a CM, one can use OVD and phaco irrigation aspiration system with this technique. It's only the matter of surgeon's choice and comfort level. Z-Vac soft chop technique is remarkably safe, very easy, and repeatable. Thank you.
Very nice and gentle surgery, sir. Any questions from the audience?
Sir, the irrigation port, the AC maintainer, if we do not use it with phaco irrigation, if we try it, what will be the problem?
No, repeat question again, not understood. Say again.
If we do not keep the AC maintainer and with the phaco irrigation we try to do the same, what will be the problem?
Nothing. You can, second case I did just to show, normally I don't use viscoelastic. I am a visco-free phaco surgeon. So second case I did with viscoelastic, so there's no difference. AC I'm using for my convenience, make surgery more safe, no fluctuation of AC, no corneal endothelial damage, no macular edema later on, no PCRs. ACM has different uses altogether. So no difference. You can do perfectly under viscoelastic, do everything under viscoelastic. You use bimanual coaxial irrigation aspiration, no problem. The technique is only basically that you don't use vacuum and ultrasound while chopping, because this can prove very dangerous in any soft cataract. Sudden disproportional parameter or sudden occlusion break, it happens. What I have seen in my life, more mature surgeon create more PCR in soft cataracts, and immature surgeon create more PCR in hard cataracts. Because mature surgeon are more confident, they want to be fast, tack, immediately things happen.
So this chopping is more mechanical in nature.
It's like you avoid pre-chopper, because pre-chopper involve extra instrument, copious viscoelastic, expensive, then raised IOP, lot of problem of OVD related. Otherwise you can use pre-chopper and have the same thing. This avoid pre-chopper.
You are using the phaco tip as
Phaco
a
tip
pre-chopper.
as a cheap. Even the same thing I do for little hard cataract also, where I feel scared that my tip leak. Like you have made a quite deep this thing groove, and you are scared that raising this ultrasound energy can penetrate through the posterior epinuclear plate. So I use the same thing. Then vacuum and ultrasound 0, I just sport it there and chop it.
Okay, sir. Thank you.
The next speaker is Dr. Prasanna Venkatraman. You will be speaking on the many phases of secondary angle closure glaucoma, a practical approach to unveil.
Good afternoon. So this is aimed at decoding angle closure in a stepwise manner. So we'll run through the video now.
Phases of secondary angle closure glaucoma, a practical approach to unveil. Secondary angle closure glaucomas can be challenging even to seasoned glaucoma experts. More often, multiple mechanisms are involved in angle closure, which can be picked up by a detailed history, gonioscopy, ASOCT, and UBM imaging. We aim to simplify the secondary angle closure by this classification to understand better. We will present a series of case scenarios and describe how we diagnosed and treated angle closure in them. Absolute pupillary block may result from formation of posterior synechiae. This patient had developed iris bombay post-cataract surgery due to persistent inflammation. Laser iridotomy was done and anterior chamber deepened immediately. However, laser PI may not be helpful in eyes with 360 degrees posterior synechiae with a flat AC as in chronic uveitis. This is a 2-week post-op image of a patient who had iris claw IOL implantation. Laser PI was done the same day. Note the immediate deepening of AC and a patent PI. Hence, it is better to do surgical PI in these patients. This patient was referred to rule out malignant glaucoma. UBM showed an FM bridging the pupillary margin. Note the position of IOL reflex. Patient was treated with intense steroids and laser PI. AC deepened post laser PI. In malignant glaucoma, one can expect forward movement of the entire lens iris diaphragm with uniformly shallow AC. This patient developed shallow AC on POD1 after iris claw IOL with a patent surgical PI, a classic presentation of malignant glaucoma. Patient was started on atropine eye drops along with post-op steroids. 3 days later, AC deepened. Undiagnosed silicone oil induced angle closure can lead to corneal decompensation as shown in these images. This image shows pupillary block by silicone oil. Post PI, silicone oil bubble retracted and AC deepened. Next is a patient who had both silicone oil induced pupillary block and silicone oil overfill in the AC. Overfill can be diagnosed by a shiny reflex over the iris as in this patient. We did a partial SOR with AC reformation and an inferior surgical PI. Inferior surgical iridectomy is helpful to prevent these problems, especially when silicone oil is done in aphex and pseudophax. Disorders involving the position and size of the lens can also result in pupillary block and secondary angle closure glaucoma. This is a case of phacomorphic glaucoma. ASOCT shows fluid-filled cleft in cataractous lens indicating a high intralenticular pressure. IOL master also shows a very shallow AC depth and lens thickness. This is the biometry of a nanophthalmic patient who underwent cataract surgery with IOL implantation. As seen here, the anterior chamber depth is shallow even after cataract surgery. UBM also points the same with a persistent angle closure. The weak and abnormally elongated zonules in microspherophakia cause an anterior movement of the lens leading to recurrent angle closure attacks. Laser PI helps in preventing the attacks. This young male with high myopia presented with acute angle closure in both eyes. UBM shows a small spirophakic lens and elongated zonules. UBM is helpful to identify the cause of IOP spikes post-cataract surgery. This image depicts the IOL position where the haptics are seen in the sulcus causing secondary angle closure with pus. The slit lamp examination shows a classic transillumination defect along with the contour of the IOL, especially at the IOL haptics. ICE syndromes are one of the notorious causes for refractory angle closure glaucomas. The abnormal endothelial cells in these eyes eventually form a membrane, the contraction of which leads to high pus. NVG is characterized by a fibrovascular membrane that gradually causes angle closure. These images represent extreme forms of ectropion UVA. These glaucomas are usually refractory, requiring multiple surgical interventions for IOP control. This patient was referred to us 1 month after an uneventful cataract surgery for iris bulge. UBM revealed multiple small to medium sized CI has a limited row patient who had severe slit lamp examination. To conclude, prompt identification and treatment is crucial for managing secondary glaucomas. Treatment can vary from a simple laser iridotomy to a complex glaucoma drainage device implantation. Thank you.
Very extensively covered, sir. Even retention of dispersive viscoelastic can cause angle closure sometimes. Have you come across such cases?
Angle closure can cause
pupil
IOP
block,
spikes.
pupil
Yeah. IOP spikes, yes.
Pupil block?
Just because of a dispersive agent, no.
Not.
If there is development of pus, sometimes do you need to manually separate the pus?
It depends on the timing of the pass. If it's a fresh pass, you can definitely do synecholysis, goniosynecholysis if you have access to gonio. If it is a chronic pass, you can release, but there is a risk of bleeding. Plus, there is a risk of reattachment of the pass. So, it does not really help the patient. So, fresh pass within 72 hours, you can do the synecholysis. Thank you.
Thank you. Next, we have Dr. Madhu Shekhar. He is showing us viscocannalostomy for safe and effective control of IOP in glaucoma.
Through this short video, I am going to share scenarios where the quest for restoring sight turned out to be life-saving. We have seen a few patients with a rare X-linked genetic disorder called Alport syndrome that involves a mutation in COL4A5 gene which encodes type 4 collagen. This presents as a triad of glomerulonephritis, sensory neural hearing loss, and eye abnormalities. Common ocular manifestations are anterior lenticonus, dot and fleck retinopathy, and posterior polymorphous corneal dystrophy. Anterior lenticonus can be diagnosed clinically using a slit lamp. Slit view shows a conical protrusion of anterior lens surface, and retroillumination shows oil droplet reflex. Preoperative aberrometry shows large myopic refractive error of more than 20 diopter spherical with more than 5 diopter of astigmatism, which is also associated with high amount of negative spherical aberrations, which is seen as bull's eye pattern on eye trace. Management is clear lens extraction with intraocular lens implantation. Now let us see a video where the surgeon has planned for a clear lens extraction in a case of anterior lenticonus. The surgery is performed through a temporal clear corneal incision. We can see that the main challenge during surgery is capsulorhexis due to highly elastic, thin and fragile capsule. Hence, it is recommended to initiate the rhexis in the mid-periphery to avoid the struggle. After completing an intact circular rhexis, hydrodissection is done and the lens aspiration done. This is then followed by single piece foldable intraocular lens implantation in the back. The post-operative result shows improved refractive and aberrometry profile. Now we can think it is a cakewalk, but it is not. Here I show you another case where a similar anterior lenticonus is seen and a clear lens extraction has been planned through a temporal clear corneal incision. We can see the similar struggle during capsulorhexis, hence the surgeon is taking a flap through the mid-periphery to complete the rhexis using a rhexis forceps. The surgery is further proceeded. But during cortex wash, there is a rhexis tear. Hence, we can say that the fragile capsule can tear any time during the surgery, making it more difficult to manage. In this case, a toric intraocular lens has been implanted as the torn area of rhexis was away from the axis of implantation. Why this topic is important to discuss. Decreased visual acuity is a real trouble, but higher order aberrations make the visual quality more worse. As the condition is associated with serious systemic illness, early diagnosis is immensely important. Most frequently, the patient presents to ophthalmologist first in view of visual complaints. Hence, we can not only restore the sight but also save the life of the patient with early diagnosis, prompt management, and referral. Thank you for watching.
Good presentation, sir. Sir, in case but should may it lead to rotation?
It can rotate, but if you use this alcon or hydrophobic, then it will stick, usually stick to that axis. It rarely rotates in that.
Is there is a extension of the axis? That's
Yes,
why
it can rotate, sir, but usually these lenses are slightly stable, hydrophobic.
Yes, sir.
Prevent the rotation if there is a tear on one side, create symmetrical tear on the other side. Put the loops at vertical axis, it will never rotate.
Very nice.
When the capsule back on tracks, the asymmetry which causes rotation. If it is symmetric, both sides, it will never rotate.
We can also use the plate haptic toric coils from Zeiss, which are more stabler.
Actually, it was planned and it was not available. So we have done it.
Thank you, sir.
Okay, sir. Thank you.
The next speaker is Dr. Vaishali Jadhav. She will be speaking on viscocanalostomy for safe and effective control of IOP in glaucoma patients.
Okay, first of all, there's no audio for the video because we were not told to have mandatory audio, so I'm just going to be talking about the video as it goes. We now present a viscocanalostomy, which is a non-penetrating surgery with less complications and risks as compared to trabeculectomy. We use a corneal traction suture with 7/0 silk to have good exposure. Atraumatic scissors are used to have a conjunctival flap and try to speed it up. Once you have the flap, we achieve hemostasis with just pledgets soaked with adrenaline. We don't use cautery because we want to protect the normal vasculature of the eye and to use the normal vascular channels and the lymphatic channels for the aqueous egress. So no cautery is done usually, unless you have to. If it's bleeding too much, we use a parabolic marker about 5 by 5 millimeters to make the superficial scleral flap. You don't necessarily have to use a parabolic marker. You can just, fashion it with a small scale that we use, calipers. We are using a diamond plate here to make the superficial scleral flap. Alternatively, an 11-number Bart Parker blade or 15-number blade can be used too. The depth of this flap is supposed to be less than what we do for trabeculectomy. So obviously it should not be so thin as to cause a perforation, but it cannot be so thick as to compromise the depth of the scleral lake that you want. So as long as it is enough that you don't see your instrument very clearly through that, but it's not so much that you see it very clearly, you can use that. So it's about 200 microns. You can use either the diamond blade or the 15-number blade for it. This is the deep scleral flap dissection. It's about 4 by 4 millimeters, so just inside to create a step. And you can then again use either the 15-number blade or the diamond blade. So you go down to the choroid and then start coming up. So the depth is thickness of the choroid. Even if you expose the choroid or a little bit of choroid pops up, it does not really cause a problem. You just see the gray reflex and you keep going forward. And you'll soon find that the crisscross scleral fibers then become circumferential. That tells you that you've reached the scleral spur. and the canal is then just in front of it. So that's the scleral spur, and then the canal is just going to be really in front of it. The dissection is carried forward gently. You enlarge it laterally, you deepen it laterally so that you can reach the thing without perforating it. You can use your cotton bud. So that's where you're trying to reach this Schlem's canal, and you've de-roofed it now. And in a bit you will see it opening up. Yeah, so the cotton bud again, and that is the Schlem's canal. You can see aqueous percolating through it. And you're trying to get the scleral fibers off, any scarring off, and that shows the percolation on the trabecular decimes membrane. Yeah, again the same thing. I never believed the Schlem's canal existed until I saw the aqueous percolating through it. Otherwise it appears like it's some imaginary structure we talk about. That's removing the inner wall of the Schlem's canal. And we just confirm cleavage of the trabecular decimes membrane from the deeper scleral flap. You then cut the deep flap is excised at the base, taking care not to puncture the trabecular decimes membrane. You can then use one as scissors to just cut it off. These are the cut edges of the Schlem's canal, and we are using a viscoelastic device to dilate the Schlem's canal. It disrupts the inner and outer walls, and sort of like a mini trabeculotomy at the junction of, at the surgical site. You can do it 3 or 4 times on either side. That's again viscodilation of the Schlem's canal. You just go about 0.5 millimeters inside, that's it. So that's your trabecular decimes window. So scleral spur, trabecular decimes window, superficial flap, that's the step that you want, and then you just suture it back. The suturing is done tightly, not like trabecular tomy where you want it little sort of, allowing egress or something.
A bit fast forward.
I'm sorry?
A bit fast forward.
Oh, yeah. So that's finished really, I'm done. That's the suture that you do. You can use tenovicryl for that, and that's about it really. Conjunctiva is sutured with the tenovicryl as well, a watertight suture. That's it, I've finished.
Very nicely done surgery, madam.
Thank you.
Any questions from the audience? The visco itself will not block the drainage?
No, it really doesn't go. It only goes 1 or 2 clock hours, and it's just supposed to disorganize the inner outer wall just there. It will not cause any rise in pressure. We are not entering the eye at all. Everything is outside.
Thank you.
Okay.
Next speaker is Dr. Sandeep Choudhury. He is speaking on phacoemulsification and bent ab interno needle goniotomy in patient of primary angle closure glaucoma.
Hello everyone, I will be discussing bent ab interno needle goniectomy with phacoemulsification and posterior chamber intraocular lens implantation in patient with primary angle closure glaucoma and cataract as treatment option. A 63-year-old female with best corrected visual acuity of 6/9, intraocular pressure of 20 on 5 topical anti-glaucoma medications, and nuclear sclerosis grade 2 cataract with advanced glaucomatoscopy was planned for a combined procedure in the right eye. Management options in such patients vary from phacoemulsification alone or combined with minimally invasive glaucoma surgeries or more invasive glaucoma surgeries like TRAP with MMC. So an alternate technique for goniotomy with a 24 gauge needle described as bent ab interno needle goniectomy was planned for the patient as a conjunctiva sparing procedure prior to going for more invasive procedures like trabeculectomy with MMC. Surgeon's position here should be temporal and the microscope is tilted about 45 degrees towards the surgeon while the patient's head is tilted away from the surgeon for better visualization of angle. The 24 gauge needle is being bent towards its bevel with the help of a needle holder. Now, a side port is being made at 9 o'clock position in the right eye. Surgeon's position here is temporal. Cohesive viscoelastic is being injected into the anterior chamber to make it deep. Some amount of cohesive viscoelastic substance is put on the anterior surface of cornea as a coupling agent for the gonio lens. Swan-Jacob direct gonio lens is being used to assess the anterior chamber angle. Now, the 24 gauge needle with bent tip is being inserted under direct visualization into the anterior chamber. The bent tip of the needle is engaged in the trabecular meshwork and the needle is moved in a swiping manner across the anterior chamber angle to strip off the trabecular meshwork. Now, the needle is being pulled out and rotated the other way so that we can treat the other direction also. In a similar manner, the bent tip is being engaged in the trabecular meshwork and then moved across the anterior chamber angle. We can note the iris falling back and a cleft being created in the anterior chamber angle. At this stage, the surgeon's position is superior and the phacoemulsification and posterior chamber intraocular lens implantation procedure is to be started. So a triplanar mean port is being made with a 2.2 mm keratome. Now, the capsular axis is being made with the microrhexis forceps. Now, the hydrodissection is being done after decompressing the anterior chamber. Now the phaco probe and the chopper is being inserted into the anterior chamber to start the phacoemulsification process. Now, after completion of cortex removal, the capsular bag is inflated with cohesive viscoelastic substance and a 3-piece intraocular lens is being implanted in the capsular bag. After removal of the viscoelastic substance, the ports are hydrated. This is the post-op day 1 photograph of the patient. We can see that the re-adhesion of trabecular meshworks post-bang are published and warrant for a longer follow-up of such patients to see the procedure's efficiency in long term. The bent ab interno needle goniectomy is an affordable add-on to the glaucoma patients who are already in the need of cataract surgery, though further studies for a long-term follow-up are needed.
I want to thank everyone for their time and patience. Thank you very much.
How many clock hours do you perform the goniotomy?
So it's about 5 to 6 clock hours.
Thank you.
Any particular reason for using only 24 gauge needle?
No, so we can use 26 or 25 gauge needle also. It has been explained in varied publications. I was more comfortable using a 24 gauge needle, that's it.
Any questions from the audience? Thank you.
Okay, thank you.
The next speaker is Dr. Sushil Oja. He will be speaking on antivitrectomy in cases of nucleus or IOL drop after phacoemulsification, done by a trained.
Good afternoon, everyone. This is a case just to demonstrate. This was the case allotted to the trainee for during early phases of phacoemulsification. He has complete on preoperative slit grading was grade 2 to 3 cataract. So we have allotted that case because in that cases holding will be there. So what happened is the resident start to make the trench and reported to me that there is no holding. So you must be aware that
Routine
what must have
hydrodissection
happened if
was done
preoperatively
in a
we are
case of
expecting something
cataract,
good hold and a
but
case is given to
once
trainee. If there
the
is no holding means
trainee
something went wrong.
gone into the
So you
anterior
just
chamber
see
to
the case,
perform the
the
phacoemulsification,
phaco is attempted.
there was no hold. Such a high opacity, there was nothing for holding in the center. So kept on decreasing the power and found that at power 10 also there was no holding. So removal of the opacified material is being performed under low bottle height and low power condition. After cleaning up the opacified lens material, what is being seen in the end is a nucleus being guided towards the vitreous cavity from a posterior capsular rent. Most likely it must have been happened during hydrodissection.
We can see nucleus is just subincisionally it is present in the vitreous cavity.
We can see the nucleus is towards the vitreous cavity and we have injected cohesive viscoelastic Helon into the anterior chamber and tried to see if any traction is happening from the vitreous towards the wound. So now we have not gone into fishing the nucleus, we have performed the remaining cortical matter aspiration and anterior vitrectomy. So with visco it is, even after removing the traction, the nucleus is not coming. So now we have removed the cortex with the help of low bottle height IA or the Simcoe cannula at low bottle height. So after removing this, we have performed anterior vitrectomy. The key point to noted is irrigation should be directed towards the anterior chamber because we want to avoid undue hydration of the vitreous. Now we are going to perform the anterior vitrectomy. So when we have done the anterior vitrectomy, what happened is we have removed the one of the piece of epinucleus. Then without going for fishing for the nucleus, what happens is nucleus started coming towards the anterior chamber. Then immediately we have injected a cohesive viscoelastic behind the nucleus and enlarged the corneal wound and removed the nucleus with the help of sandwich method. So what was in our plan was to just perform anterior vitrectomy and refer patient to VR surgeon so that patient have a clear cornea and reduce risk of secondary glaucoma. But what happened is, without causing any undue traction, with even simple vitrectomy, nucleus has come into the anterior chamber and we have removed it. Now our plan is secondary scleral fixated sutureless or suture IOL in the eye, depending upon the recovery, because patient is very old, 85 years old patient is. So if patient is ready for second surgery, we will perform secondary IOL in the eye.
So after this, we have to again do the vitrectomy, complete the vitrectomy and suture the corneal wound, and we can plan a secondary IOL, or we can give the FAK glasses also, because patient is of 85-year-old, may not be willing for a secondary surgery.
When the piece dropped, there was a good rhexis margin present.
Rhexis sulcus was
Sulcus was there. So multi-piece lens placement in the sulcus, was that your plan?
Actually, sir, because of the age, there may be, because we are not aware when did the nucleus got dropped. During hydro only it was dropped. So to see later on that if there is good fibrosis, we can implant in the sulcus. But we have to reassess the patient, because we don't know where is the defect and how large it can be. Because simple hydro, if the nucleus is dropped, then there may be risk of IOL drop also. So primary setting we have avoided, but yes, we can do it in a secondary setting when your sulcus is also very good after post-operative fibrosis. So we are planning it secondary due to the age and also due to the unexpected complication which we are not expecting pre-operative.
Actually, what we do actually, we do what is our VR colleague is comfortable with. Sometimes we have a hard nucleus drop. Some here are not comfortable with those phacofragmentum. They want to take it out with the wound, so we do not place the IOL then. But some VRs are comfortable with the phacofragmentum, and that case we do the cortical wash with and place the IOL and then send him.
One thing which I would not have done in this case was, before entering into the AC with the bacterial infusion, I would have made the main move totally toward the vitreous attachments, moved it, made sure that either valve is functioning properly to close it when the fluid goes inside, or I would have put suture before going to the vitreous. Because when you went to the vitreous, in the fluid in the AC, the vitreous was coming out. It's not only you go with the bar bacteria, fish out, it will cause detachment. Even there's so much traction the vitreous gives when the vitreous comes out into so much bottom height, it can also create the same thing. So one should not enter the anterior chamber unless to make sure that the wound, main wound is totally
clear of it. Lucky that the vitreous was in the gel form, otherwise it was dropped from the tip. Thank you.
Because of the age, it may be in the gel form.
The next speaker is Dr. Rakesh Shakya. I will be speaking on my mentor always said every cloud has a silver lining.
Every cloud has a silver lining. That implies one should have inherent optimism in facing life challenges. a young one-eyed patient, only Bible eye vision of PL, always accompanied by someone. He was denied surgery everywhere, but he had glimmer of last hope and came to our hospital. When the patient presented to me, it was not less than a nightmare to think of operating on such a patient. But I have the belief that beyond the gloom, something positive awaits. So this is a video of patient hope in my audio. This is the right eye of a 22-year-old male having the vision of only light perception with inaccurate projection of the ray. There was a occlusive pupil with complicated cataract and 360-degree synechiae is present and IOP was 28 mm Ag. Other eye was thysical valvi. I decided to do the phacoemulsification with IL with pupil expander and intravitreal injection of the time slot. After making the side foot, Bisco injected vigorously, so deepen the chamber and break the synechia. And clear corneal tunnel is the made to avoiding the area of the antisynechia. Now I saw the pupillary membrane was very thick, so I decided to cut with the help of the one-hour scissor, and then I try to peel off the membrane, but membrane is very thick, so I have used the retractor to cut the pupillary membrane. With the help of the retractor, so I try to make a pupil slightly circular. Postsynechia was broken with the help of the iris repositor. Then I used the B-hex ring to expand the pupil. After that, cystitome used to give the nick in the entry capsule, and then rhexis is completed with the atrata forceps. So lens was very soft, so we kept the phaco-parameters very low and then tried to aspirate the lens. As I was aspirating the lens matter, there was a inadvertent journal dialysis. So after inserting the CTR, aspirating the lens matter is very easy. And then I try to inject the foldable lens. But the lens was very bulky, so refused to go into the bag after the repeated attempt. But unfortunately, the B-hex ring got engaged with the aisle. So I decided to remove the B-hex ring. By removing the B-hex ring, some vitreous prolapse I noticed. Some vitreous is seen to be pulled. So I had to do the antivitrectomy. I decided to cut the aisle and explant it. The rhexis margins were intact and bag appeared fine, so I decided to use the less bulky PCI and was easily inserted into the bag. In spite of all the difficulties I faced, at this point I felt happy, but picture abhi baki hai. After the lens stability confirmed, I gave the intravitreal injection. So when I injected the intravitreal time salon, I noticed the air bubble inadvertently got injected. Due to the air bubble, I was slightly displaced toward the antechamber, tilted out of the bag. So soon there was iris prolapsing through the tunnel. In spite of repeatedly hydrating the port, oil was not remaining stable. After antivitrectomy, I reposited the iris and closed the case. On the 7th post-op day, his vision was counterfinger. There was a dense fibrin membrane in the antechamber. aisle was descended. So I took the patient for iodine. Iris lens capsule adhesion were also released. After 1 month, patient was happy. His vision was 6 by 36. So all's well that ends well. Just as the sunlight break through the cloud cover, so to do movements of grace and resilience shine through in our life. As my mentor says, every cloud has a silver lining. Hurdles are like passing clouds which cast shadows, embrace optimism. Thank you. Thank you.
Very extensively managed. Instead of using the BX ring, you should have continued with the vitrectomy cutter to enlarge the pupil further. And I think you should have used the 3-piece IOL that would have fitted better in the bag rather than a single-piece IOL.
Actually, the bag area is very small. So why this region we can we have the option only the put the oil in the sulcus. But I try to put the oil in the bag because due to the adhesion in between the capsule it's there. After the removing the adhesion, but the adhesion was not properly detached. So by this reason I put the oil in the bag. Initially I put the oil slightly bulky because I after the putting this oil and then after the surgery I saw the actually I reviewed the literature. This plate haptic is contraindicated in this type of cases.
No. Prolate haptic 3-piece IOL, it is more malleable. It can be put in the bag also. Need not always be put in the.
Yes, sir. But bag is very shrunken. So why this region actually less bulky oil is I put it.
And intravitreal tricot you give routinely?
Yes, if the pupillary membrane is very thick, then I use always. In this case,
you give it?
intraoperatively.
Causes of IOP spike and all?
In some cases, actually. In some cases, we find the IOP, but in this cases also have the secondary glaucoma. Actually, pre-op IOP was 28. But after the medication, the IOP was actually less and there is a control.
Especially in such cases where there is a posterior synechiae with a pupillary membrane.
Yes.
There is a study from LV Professor where they advised transeptal tricot, like a peribulbar injection, 0.5 cc, without causing an IOP spike.
You can give PST also.
Yes, I agree with you. The study just say, but the many study also say the intravitreal is the best for the posterior segments inflammation also. Yes, sir. Okay.
Thank you. Okay,
thank you, sir.
We have Dr. Sachidanand Pani. His topic is surgical demonstration of silicone tube intubation for DCR and canalicular obstruction.
Good afternoon, everyone. I will be demonstrating methods of silicone tube bicanalicular silicone tube intubation in DCR patients.
Surgical demonstration of silicone tube intubation for DCR and canalicular obstruction. The purpose of this video is to demonstrate the different techniques of silicone tube intubation which can be used in patients with DCR, failed DCR, and primary canalicular obstruction with minimal invasion. This is a prospective interventional study conducted between August 2022 and August 2023 on 66 participants. For all patients, dacryocysto-rhinostomy using the bicanalicular stent was performed. For each patient, the probe with the silicone tube was inserted into the puncti, advanced through the canaliculi and pulled out from the cavity of the lacrimal sac. In this video, we will be demonstrating 3 different techniques to retrieve the silicone tubes through the surgically created ostium and ultimately the nostrils. In the first technique, the metal probes are clamped using artery forceps after being passed through the lacrimal sac. These clamped probes are then gradually maneuvered into the ostium. Another artery forceps is introduced into the ipsilateral nasal cavity that is used to retrieve the ends of the metal probes. These probes are then brought out through the nostrils, cut from the silicone tube and tied. In the second technique, the metal probes are cut and separated from the silicone tube after being passed through the lacrimal sac. The ends of the silicone tube are then passed through the ostium and brought out through the nostrils. The visualized ends are then tied subsequently. Here we can see the metal probes being cut from the silicone tubes and the free silicone ends being gradually guided through the ostium using an artery forceps in the nasal cavity. These ends are then retrieved from the nose and pulled out using another artery forceps. In the third technique, similar to the second, the metal probes are cut and separated from the silicone tube after being passed through the lacrimal sac. However, in this technique, the free ends of the silicone tube are tied and anchored to the gauze piece used for nasal packing, and then guided out through the ostium and externalized at the nostrils. The free ends of the silicone tube are tied again and the excess is cut. The anastomosis is established by suturing the anterior flap of lacrimal sac and nasal mucosa. The wound is then closed in 2 layers by suturing the muscle and then the skin. Complications of this procedure may be prolapse of stent loop or prolapse of stent with exposure of mouth. In such patients, stent is usually removed 3 months following surgery. Between August 2022 and August 2023, using the above mentioned methods, we have placed silicone tubes in 66 patients. The intubation was performed for 40 DCRs, 16 failed DCRs, and for 10 primary canalicular obstruction. We did not encounter any difficulty related to the technique in any case. The silicone tubes were removed 3 months later. In conclusion, techniques described in the study are easy to understand and perform. These techniques are relatively non-traumatic and inexpensive. Of the different types of silicone tube intubation techniques demonstrated in the video, one can adopt and perform the technique suitable for the surgeon.
Thank you. Very nice presentation. Thank you. Any questions?
Do you give a silicone tube in every case of DCR?
No, sir. For some cases only, where canalicular patency will be not that much will do.
Okay. Or failed DCR as you have said.
Yes, sir. Or failed DCR.
Okay. Thank you.
The next speaker is Dr. Ipsita Konar. She will be speaking on Paul glaucoma implant surgical technique.
Hello. Hello. Thank you for this opportunity. I'm just going to go ahead and play the video. Today's video is about the Paul's glaucoma implant, and I am Dr. Ipsita, your voice for this video. The following surgery is being carried out in Stanley Eye Unit, Abergele Hospital. We begin the surgery with traction suture using 7/0 silk to rotate the eye in downward gaze. We mark the cornea to note the quadrant. We go on to make conjunctiva and tenons peritomy. We use Vanna scissors to open up the conjunctiva and nobles to extend the incision. We need to release any adhesions and make an adequate pocket for the tube. Relaxing incisions are needed on either side. Flush the tube with sterile saline to ensure tube flow. We go ahead and thread the tube with a 6/0 Prolene suture. The purpose is to prevent early postoperative hypotony. Next, the recti are located and held using the squint hook, and the plate is then guided beneath the recti on either side. The The plate is then sutured to the sclera 8 to 10 millimeters back from the limbus using 9 nylon on both sides. You can see how the needle is first being passed through the hole in the tube and then scleral bite is taken to secure the plate. Conjunctival pocket is created to place the other end of the Prolene suture we use to thread the tube so that it can be easily removed under slit lamp in the clinic. Minimal cautery is applied to the scleral bed. The tube is cut in a beveled fashion to maintain adequate length in the anterior chamber. We make horizontal incision on the sclera using a diamond plate and use a bent 26 gauge needle to make a tunnel for the tube to pass. The tube is then guided into the anterior chamber. Here we can be seen putting box sutures using 9 nylon to secure the tube to the sclera. We use tutoplast on top of the tube to prevent conjunctival erosion. The conjunctiva is then repositioned using slip knots on either side. The relaxing conjunctival incisions are then sutured back to place. We finish the surgery by removing the traction sutures and giving subconjunctival antibiotic and steroid injection. So that was a meticulously done surgery. The next question is, why are we using the Paul's tube in refractory glaucomas in our unit? We did the retrospective analysis of postoperative outcomes and complications of patients who had the Paul's glaucoma implant inserted. Our outcomes can be classified into primary and secondary, where primary includes surgical success, qualified success, and failure, and secondary outcomes include safety parameters. To define these terms as per the World Glaucoma Association guidelines, surgical success is defined as IOP of 5 to 18 millimeters of mercury or at least 20% reduction without IOP lowering drops, and qualified success is the same definition but with or without IOP lowering drops. We followed up 26 eyes of 25 patients. Different types of glaucoma were included in the study, and the mean preoperative IOP we began with was 32 plus minus 10. If we look at the mean intraocular pressure over time, they are significantly lower till 2 years follow-up postoperatively, and they're all statistically significant. For 8 eyes at a mean of 6 months, Prolene suture was removed to result in a mean IOP reduction of 8 millimeters of mercury. 11 out of 26 eyes required IOP lowering drops postoperatively over 2 years. However, the number of medications reduced from 4 plus minus 0.7 to about 0.9 plus minus 1, which was statistically significant. Surgical success ranged from 73% at 6 months to 37% at 24 months, whereas qualified success was at 100% for 12 and 18 months. 2 out of 23 eyes, that is 8.6%, could be classified as failure as per the definition. Looking at safety outcomes, there were no intraoperative complications or hypotony or wound leak, no prolonged or recurrent inflammation, no corneal decompensation or loss of vision. 2 cases required tube repositioning, 1 required plate and tube repositioning, 1 case of transient diplopia, and another case of persistent cystoid macular edema resolving after a year was noted. Our study was compared to 2 previous studies by Ko et al. And Vallabh et al., and as you can see, the values are quite similar in all the 3 studies. So when compared, our results with IOP and medication reduction are similar to previous studies with no significant safety issues. When compared to the Ahmed-Bawalt comparison study, the Pauls had a similar IOP at 1 year and required less medications at 1 year, at the same time had lesser complications than the other 2 devices. The limitation of our study was less number of patients and a small period of follow-up. However, that's about it. We found out that the Pauls, like it was found out in the other studies, did pretty well with the results, whether it was the reduction of IOP or reducing the number of drops even when it was needed. Thank you.
Thank you. As we are lagging behind the time, I will call the next presenter, Dr. Ravish Vaishnav.
Good afternoon all. My video is based on few non-routine cases which I encountered during my practice.
Hello all. First of all, I would like to thank the scientific committee for giving me this opportunity. Moving on to my topic. Today I will be discussing few tips on how to tackle challenges encountered during our surgeries. As surgeons, we get exposed to different type of cases which may be complicated to start with or may develop complication intraoperatively. So it is important to do your homework beforehand and plan each case accordingly, especially when you are new in your practice. A surgeon should be at ease while operating his cases. For example, preferring a block over topical whenever the situation demands, and so on. Staining with Trypan blue dye provides for better visualization, allowing the surgeon to perform the capsulorhexis with greater safety and much more confidence. It is important to debulk the anterior capsule with a straight 26G needle and aspirate the fluid out, thus reducing the intraventricular pressure and easing the rhexis formation. Rhexis runaways could also be prevented by making a spiral rhexis, wherein a small rhexis is made first, followed by enlargement of the rhexis in a spiral manner and completing it all around. Dealing with small pupil is always challenging. Here I am using the Y-hook spatulas to stretch the pupil to attain some good adequate pupillary dilatation. Good pupillary dilatation enables us to place the toric IOL at the required axis. Here, as the staining is not done adequately, it is difficult to visualize the rhexis. Thus, the microrhexis forceps comes to our aid here and we are able to complete the rhexis. Posterior synechiae have to be carefully dealt with. Using the iris spatula can thoroughly release the synechiae from the anterior lens capsule and help in adequate pupillary dilatation. There is a routine case which was planned for toric IOL placement. A few minutes into the case, I noticed that the pupil is getting smaller. And the iris is becoming floppy. At this point, I stop and talk to the patient and ask him whether he is using any medications for his urine or prostate problem. The patient replied, हाँ डॉक्टर साहब मैं तो एक टैबलेट काफ़ी सालों से खा रहा हूँ. I was surprised and I asked him कि आपने मुझे चेकअप के टाइम क्यों नहीं बताया जब मैंने आपको पूछा था. He was like कि मुझे लगा ज़रूरत नहीं है, एक ही टैबलेट है, ये बताने की ज़रूरत नहीं है. Feeling helpless, I continued the case. I used epitate and viscoelastic injection to maintain the pupillary dilatation. And luckily for me, I could finish the case well and the lens was placed well in the position. Here is an interesting case. Everything went on smoothly, the phaco part, the cortex part, the IOL also was implanted into the bag. But suddenly while removing the visco, I noticed that the IOL keeps on decentering. On nudging with the lens dialer, I noticed that the haptic is half broken. I was confused as to what to do next. As the haptic was half broken, I decided to keep the lens as it is, as a partial decentration won't matter a lot in a myotic pupil. Later on, I watched the the leading haptic was broken. I was eager to know where it actually happened. So I rewatched the recording carefully and saw that while loading the IOL in the cartridge, the leading haptic got stuck in the cartridge while locking it. And this was the reason for the broken haptic. Thus, to sum up, it is important to plan each case individually and be vigilant about each and every step. A well done case makes you sleep well through the night.
Very nicely summed up with salient features. Thank you.
Thank you, sir. Thank you so much, sir.
The next speaker is Dr. Berry.
Good afternoon, respected seniors and dear friends. My name is Dr. Nitika Berry, and can I please have the slides video? Acha, okay, sorry.
Use of acrosangiography to augment surgical outcomes of minimally invasive glaucoma surgeries. Acrosangiography is a technique introduced in 2017 to
So acrosangiography is a recently introduced technique in 2017, and it studies the trabecular aqueous outflow pathways and helps us visualize it. So we use the endocyanin green dye in a concentration of 0.5% and even 0.1% are used. And this is the flex module of Spectralis HRA OCT, no financial disclosures. And I would like to show you how it looks like.
Proximal to distal endocyanin green dye, 0.1 ml of which is injected is now being explored to the anterior chamber and images captured using the machine. Aquasangiography.
Okay, so the dye is injected into the anterior chamber and we can visualize the flow of the dye, which is the angiographically positive regions. These denote the aqueous outflow pathways along the limbus.
In non-glaucomatous eyes, showing 360-degree high flow regions of aqueous outflow channels.
So we can see a very good flow.
Another example of aquasangiography in non-glaucomatous eyes showing segmental pattern, that is high flow region in nasal and low flow region.
So this is the most common pattern that we've seen in most of the patients. The nasal quadrant is generally the high flow region and the temporal quadrant is generally the low flow region. So in most of the patients, we've noted a segmental aqueous outflow.
In temporal quadrant. Clinical.
So why do we need aquasangiography and what are the clinical implications? How can it help us, make surgeries more easier and better? So aquasangiography helps to study the effect of MIGS on aqueous humor outflow pathways, discover the cause of failure, and also help us to intraoperatively assess the functionality of MIGS procedures. I would like to elaborate a few of my points with the help of some cases, please.
Applications of aquasangiography are of MI was a 58-year-old male.
So this was a 58-year-old male with a diagnosis of both eyes mild primary open-angle glaucoma with immature senile cataract. We performed a left eye stent inject and performed an aquasangiography after insertion of the eye stent inject. So I would like to show you the video.
With mild primary scopic view after eye stent inject, one was inserted at 10 o'clock position denoted.
So as you can see, these are two anatomically well-placed eye stent injects denoted by the green asterisk and denoted by the blue asterisk.
By the green asterisk, and the other was inserted at the 8 o'clock position denoted by the blue inject.
So, just a second.
By the blue asterisk, showing clinically adequate positioning of both the eye stent injects.
So we can
aquasangiography performed post eye stent inject.
So we can see a very good collector channel through one and absence of the collector channel through the other. So this shows that only one was functional. So moving on to the other case. Okay, it was a 62-year-old female, moderate pseudophakic glaucoma. So we performed aquasangiography before performing the MIGS procedure, that is BANG, and found the nasal quadrant to be the high flow region. And after BANG, we did a repeat aquasangiography to see. And what we found were increased signals.
In the nasal high flow region. Pre-BANG aquasangiography showing high flow region in the nasal quadrant.
In the nasal quadrant.
Visualize the clear demarcation of trabecular meshwork due to green color staining by ICG.
And we saw
Moving on to our third case of angiography
we
showing
saw increased angiographic signals on repeat angiography, indicating a better flow now. In the third case, it was a diagnosis of severe primary open-angle glaucoma, and we performed aqueous angiography, which revealed very poor aqueous outflow. And we planned for a trabeculectomy in this case. What we've done this was a severe case, but even in mild and moderate primary open-angle glaucomas, we found a severe lack of aqueous outflow. And in those cases, rather than going for an MIGS, we've preferred doing a trap procedure rather than this one, and vice versa. In a severe case, if we found a good aqueous outflow, we've preferred a MIGS over a trap to buy us time, because in glaucoma surgeries, we are actually buying time for the patient.
Of aqueous outflow through the patient. Endocyanin green dye is injected into the anterior chamber, and enhancement of the anterior chamber is seen with an air bubble casting a black shadow in the center of anterior chamber, which is an artifact. A single collected channel outflow through trabecular meshwork, we planned the patient for trabeculectomy instead of MIGS with phacoemulsification. Through these cases, we would like to summarize that aqueous angiography allows for assessing the
functionality of an MIGS procedure. It allows us to individualize and target the MIGS procedure in either a high flow or a low flow region, which can be seen through this. And it also allows us to take a decision between an MIGS or a conventional glaucoma surgery. And it is a nascent technique. And
of conventional glaucoma surgery. Our take-home message is
it is a nascent technique and has great prospects in futures to increase the success of MIGS in glaucoma patients. Thank you very much.
Very nice technique if you have the facilities.
Yes. The limitations are it is invasive, you can't perform a repeat one, and the machine is expensive as of now, sir. We are hoping that it can be bought down, one, and if we can do a research on which to perform, then it will be better, sir.
Definitely.
Yes, sir. Yes, sir. There is a flex module, sir, with a... Yes, sir. No, on the chair itself, sir. Yes. Sir, yes, sir. But yes, sir. Sir, to be honest, we are undergoing an early study, and we did some patients and analyzed the data on a 6-month IOP basis, and we've actually found that performing a bang in the temporal quadrant is showing better results. So, though that is under yet process, sir, the hypothesis is that we are going to prevent scarring in the high flow region. Like if you perform an excisional procedure, it incites a scarring. So let's save the good part. And sir, there's another case which we performed, which I have not included in this presentation. So we localized the low flow region and performed a bang there. And we found new recruitment of channels, sir. So now we are trying to get we've seen that it is segmental. So let's perform bang by default on the temporal quadrant, save the better high flow region from scarring. Let's hope that some new channels form. So for a better decrease in IOP, sir. But this is still under this thing, and we need more people to do this so that the results can be validated, please. Yes. No. It's an OT procedure, ma'am. It's an OT procedure. It's an invasive procedure. So any patient we are taking up for cataract surgery, just we inject the dye. And the added advantage is, ma'am, that endocyanin green acts like a capsular stain also during phacoemulsification. So there's not much of a problem. Yes.
Thank you.
Thank you.
The next speaker is Dr. Vivekanandan VR. He will be speaking on flanges for beginners.
Good afternoon, everybody. So this video demonstrates a few new techniques by me using the flanges for doing complex procedures. I will go into the video.
In the world of ophthalmic surgery, we encounter multiple challenging scenarios. These procedures can be incredibly difficult, requiring high levels of skill, precision, and experience. We wish we had a tool as simple and strong as this. We came across the gonioscopy-assisted transluminal trabeculotomy procedure developed by Dr. Davinder Grover and Dr. Ronald Feldman. In this procedure, the tip of a Prolene suture is cauterized to create a flange, which is then introduced into the Schlemm's canal, allowing a 360-degree trabeculotomy to be completed. This led us to the path of replacing the traditional knots with flanges. Now, just like Thor and his mighty hammer Mjolnir, we too have a powerful tool at our disposal, the flanges. Our first challenge was dealing with cases of large zonular dialysis or gross zonular weakness, such as in this microspherophakia case, where a capsular tension ring alone may not provide sufficient support. In these cases, a capsular tension segment is also required. We carefully completed a rhexis and inserted the CTR. Capsular hooks were then used to anchor the back complex, and phacoemulsification was performed with lower parameters. 2 sclerotomies were made using a 30 gauge needle 6 clock hours apart. One end of a 7/0 Prolene suture was threaded through the needle and exteriorized, while the other end of the suture was passed through the eyelet on the CTS and flanged until it was larger than the eyelet itself. The suture was pulled, simultaneously positioning the CTS in the bag, following which the suture was trimmed, flanged, and buried underneath the tenons. This procedure was repeated on the other side, and an intraocular lens was placed in the eye. This technique reduces surgical time and the number of sclerotomies needed by at least half. Our second encounter, managing an iododialysis repair. This is a case of traumatic cataract with a 4 clock hour of iododialysis. An iris hook is used to keep the iododialysis at bay, and careful phacoemulsification is performed. After IOL implantation, the anterior chamber is filled with a combination of cohesive and dispersive viscoelastic, mainly to flatten the iris and to keep the AC formed. The extent of the iododialysis is measured and the anchor points are marked. While moving the conjunctiva radially towards the limbus, a long spatulated needle attached to a 7/0 Prolene suture is inserted into the eye, ab externo at the iris plane, and passed to the peripheral iris with the help of a microforceps and externalized through the clear corneal incision. A U-turn is made with the same needle and reintroduced through the same incision, passed through the peripheral iris at the second anchoring point and externalized to the ab interno route. This creates a U-loop. The sutures are pulled to approximate the iododialysis. One end is trimmed and a 1.5 mm of the suture is flanged. The other end of the suture is pulled, burying the first flange under the tenons, plugging the sclerotomy. Similarly, the other end is trimmed, flanged, and buried. The overlying conjunctiva is ironed out to make sure the flanges are below the tenons. Though phacoemulsification is the gold standard for cataract surgery in cases such as this, our options are either ECCE or MSICS. In developing countries, these cases are common, and MSICS with PMMA lens is the preferred technique. These lenses have holes in the optic mainly to facilitate IOL dialing. Inspired by Yamane and Canabrava's techniques, we developed our modification. A sclerocorneal tunnel is constructed and the cataract is extracted. A thorough anterior vitrectomy is done and the anterior chamber is formed. Displacing the conjunctiva radially towards the limbus, a sclerotomy is created using a spatulated needle attached to a 7/0 Prolene suture. The second sclerotomy is done 6 clock hours apart while ensuring one sclerotomy is at the tunnel site. The needles are docked into an irrigating cannula and externalized through the sclerocorneal tunnel. Once both sutures are out of the tunnel, the sutures are passed from above to below through the dialing holes of the PMMA lens and flanged until they are larger than the hole itself. The IOL is placed behind the iris and the sutures from the sclerotomies are pulled to center the IOL. Now the IOL is descended slightly towards the transconjunctival site, held close to the sclera, trimmed to around 1.5 mm and flanged. The flange is buried by lifting the surrounding conjunctiva and tenons while simultaneously pulling on the second suture. The second suture is then held close to the sclera, indenting it, trimmed to around 1.5 mm and flanged. It is as simple as that. The procedure can be performed with single-piece foldable IOLs as well, by creating 2 sclerotomies, 90 degrees away from the clear corneal incisions, pulled, trimmed, flanged, and buried to plug the sclerotomies. Dive radially towards the limbus. conjunctival erosion, which could be due to a large or a fat flange required to plug large sclerotomies. We have a few suggestions to overcome these complications. Move the conjunctiva radially towards the limbus before making the sclerotomy to ensure intact conjunctiva covers the flanges at the end of surgery. Use a spatulated needle attached to a Prolene suture, which can reduce the size of the sclerotomy by more than 50% compared to gauge needles. This reduces the length of the suture to be flanged from over 3 mm to around 1.5 mm, resulting in a much smaller flange. Ensure that the suture and the surrounding area are dry before flanging. Create the flanges by holding the thermocautery adjacent to the suture tip without touching it. This avoids sharp edges that can cause suture exposure and
surgeries. Any long-term follow-ups where the flanges have given away?
We've done, no sir, no. We've done around more than 1,000 SFIOL so far. I've trained all my fellows and colleagues to do this. Around 20 surgeons are doing it in Aravind Pondicherry, and we've trained other doctors from Aravind Hospital in other centers as well. They're doing. So iridodialysis we've not done much, maybe around 15, 17 cases. CTS placement around 20 cases we've done. But whereas SFILs, since we are a training institute, we have a lot of training happening, complications happening. So we've done over 1,000 in the last 3.5 years.
No cases of any...
We had a learning process initially, sir. The reason why we designed, the initial thing was we were docking it in a 26 gauge needle, but the flanges were so big. In thin conjunctivas, you can see a tear film elevation, but the flanges are always round. What we've learned through the process is when you touch the suture with the cautery, you have sharp edges. So you do not touch, you just go close to it, you allow it to melt. But the bulge was a concern. Even though it is the tear film, we didn't want it to be elevated. We wanted to plug the sclerotomy very snugly. So then we decided this needle, like I said, it's a spatulated needle attached to the suture. So you don't have to, it's almost like half the size, and it is a very thin slit. So just a little bit of flanging is enough to plug it. And we've done a few dry lab tests to compare the flanges with the knots, how strong are they and all that. So the flanges are really strong, and the force required to make the sclerotomy with this special needle is also so less that there is less internal damage. So
very nice, sir. Thank you.
Thank you. You can do that, madam. You can do that. We did that initially. Then we thought it's not required. Time consuming. We did peritomy, and then now we've with this very little bit flanging, you won't see anything. You'll just see a small dot, but you cannot see any elevation on the conjunctiva. Yes, madam. So that the other main part that moving the conjunctiva along with thenons radially before doing the sclerotomy, that gives us, because initially when we were doing directly, you're always praying that nothing happens the next day. But this one, we are very, very confident, because conjunctiva heals and scars very quickly. Is a little easier for us. 70 Prolene sutures, 70. Because why 70 is we couldn't make a thinner needle, but this needle we can do only with 70 and 60. 50 is a little fatter, then again the sclerotomy becomes big, so that was the reason. Oh, yes. Yes. Bring it ahead. So the biggest learning was how to bury the flange underneath intact conjunctiva. So we figured it out that you pull the suture on the opposite side and just lift the conjunctiva around the flange area with the thenons. You just keep lifting it, it will get buried. And how to verify it is when you swipe or squeeze over that. If the flange is moving, it is still stuck between the conjunctiva and thenons. If it is not moving, then you can be sure that it's plugging the sclerotomy. Thanks.
Very nicely presented.
Thank you, sir.
Thank you, everyone. I think this is the first session since morning where all the speakers have come. Thank you very much. Can we assemble for a group photo?